has tried to train me. Okay, so today we're going to talk about some endocrine disorders, and we've talked about endocrine quite a bit in the past, a lot about diabetes for sure. We know that the endocrine and our hormones, those systems are sort of controlling a whole slew of things throughout the body. The hormones are secreted by different glands, and they control any number of different functions, if you will. The pituitary gland and the hypothalamus are sort of the master glands of the endocrine system. That's where there's they sort of set the stage for all the other glands, if you will. And the different things they impact: growth, metabolism, sexual development, functions, things like that. What puts you at risk for problems? Well, certainly age, heredity, congenital issues, environmental issues, trauma, things like that. So you've got the glands secreting hormones, and then out there throughout the body, there are receptors just waiting for the hormones to pass by and to make their influence. So we've got these next two slides are two pictures, if you will, cartoons might be another way to describe it, of some of the different glands and what they are helping to control and influence throughout the body. Again, with the hypothalamus and the pituitary gland up in the brain, the thyroid and the parathyroid at the neck, the thymus in the mediastinal area. Pancreas is an organ unto itself. The adrenal glands hanging out near the kidneys, just outside the kidneys, and then the ovaries or the testes. And then this next one shows what the glands are actually secreting, if you will. It's not pineal. Is it pineal? I'm having a brain cramp. Anyhow, that's, say that again, please.
Pineal.
Pineal, thank you. Secretes melatonin. Pituitary's got a whole slew, growth hormone, ACTH, thyroid stimulating hormone. Again, brain cramp, can't remember. I know it's follicle stimulating hormone.
Yeah, follicle stimulating.
Thank you.
Yep.
Luteinizing.
Oh, thank you.
Luteinizing hormone.
There you go. Thank God you guys know what you're talking about. Thyroid, parathyroid. So sort of these two pictures together can give you some information about what each of the glands do. So the hypothalamus, again, which is up in the brain, helps determine whether it should influence what is released from the pituitary gland. The hypothalamus essentially tells the pituitary gland what to do, if you will. And again, the hormones work on a feedback system. So small amounts make a change. There's feedback back to the gland as to whether more is needed, less is needed. And when that feedback, there can be problems in the gland itself where it's not able to make the hormone it's expected to make, or there can be a problem in the feedback loop, if you will. And hormones work in a couple of different ways. Some are synergistic, meaning they work together with other substances to make a difference. An example of that is aldosterone, an antidiuretic hormone, ADH. I know it's going to sound sillier than usual, but I like antidiuretic hormone. ADH, it literally tells me what it does. Antidiuretic hormone. So when there's too much ADH, the body is not going to diurese. It is literally going to tell the body, hold on to fluid. Even I can understand that in its simple terms, if you will. Then there's other antagonistic hormones like atrial nucleic peptides, where when there's high blood pressure, ANP is released, and that makes the kidneys secrete more water or extract, exude, and eliminate more water so that it'll help decrease blood pressure. It's going to work the opposite of antidiuretic hormone, if you will. And then there are permissive hormones where you need this in addition to other substances so that something can happen. For instance, a thyroid hormone is necessary for the growth hormone to be able to do its work. You can have all the growth hormone you need, but if the thyroid's not working, you're not going to get the full effect of growth hormone. Some are lipid soluble, some are water soluble. That's all way more technical than we need to know per se, but it's interesting nonetheless. The other thing is many of these hormones, you can track blood levels. You're able to draw bloods to see whether they're high or low and help figure out what's going on. The pituitary gland, again, is working in concert with the hypothalamus. There is both an anterior and a posterior lobe of the pituitary gland. It's the anterior pituitary that's regulated by the hypothalamus. And because these two are both up in the brain, their functioning can be influenced by its environment within the cranium, if you will. So what do you think I mean by that? Any idea?
Intracranial pressure?
Exactly. Who said that?
Sammy?
Sammy, you're going to get a gold star for the day. That's exactly right. So increased intracranial pressure can potentially influence the work of the pituitary, the hypothalamus and the pituitary gland. And so if somebody has had a stroke, somebody's had a head injury, somebody has had intracranial surgery, those things can influence the way the hypothalamus and subsequently the pituitary gland work. So what do we do? What do we need to assess for in patients like that? Jack, Tiffany, you can jump in here anytime. What are we sensitive to from an assessment perspective?
What is exactly the question? Can you say it again, please?
I can, yes. So if you've had somebody that's has potential for increased intracranial pressure, and it might be impacting what the hypothalamus and the pituitary gland do, what are we assessing for? What might we see? So because they help control The anti,
Regular pupils.
what was that, Jack?
I was gonna say like irregular pupil exams.
No,
Temperature intolerance.
The increase of adrenocorticotropic hormone to increase the the excretion of sodium, for example, or and liquid.
Yep. Right, so
Antivasopressin. Yeah,
that's what I was looking for, Eugene.
that's a complex mechanism, hard to
Right.
answer.
So those two glands work together to help influence antidiuretic hormone, or actually they decrease the secretion of antidiuretic hormone. So these folks might be prone to excessive fluid loss through urine. So you're always looking at I's and O's to see if there's any increase, unexplained increase in urine output. That was a roundabout, not particularly elegant way to get there, but do you see how you don't necessarily link those together, but yet they're significant and you need to know that relationship with head injury and stroke and things like that.
It is a similar mechanism for diabetes insipidus. So when, yeah.
Yep, and we get to DI in a little bit. You're right, Eugene. So the anterior lobe of the pituitary gland, growth hormone, thyroid stimulating hormone. I should have had this list earlier. Also, the posterior lobe is oxytocin and ADH. So alterations in the pituitary gland can lead to excess growth hormone, where you're going to get, you can get excessive growth, acromegalia, might be a problem. The thyroid gland. So now again, the thyroid gland, let's go back a couple. So you've got the pituitary gland that is secreting thyroid stimulating hormone. So the pituitary gland secretes thyroid stimulating hormone. It wanders on down to the I'm going the wrong way, son of a gun. Wanders on down to the thyroid and says, excuse me, could you do your thing, please? And then the thyroid secretes T4 and T3. And this is why when we're looking at the function of the thyroid, you need to send tests that check TSH level, T3 level, and T4 level. If you have a high TSH level, that means, well, the body, the brain recognizes that the thyroid's not doing its thing because it's secreting more and more stimulating hormone, but the thyroid's not responding. So if you see a high TSH level, but low T3, T4, the problem's in the thyroid. If you see low T3, T4, and low TSH, the problem's upstairs because TSH is not being secreted to tell the thyroid to secrete more T3, T4. The thyroid may work just fine. It's just not getting the signal it needs, i.e. the TSH, to produce more T3, T4. So that's why you need to send all three of those tests if you're assessing the function of the thyroid. Does that make sense?
Yeah, it does.
Okay. And then when we're concerned about calcium levels, particularly when they're high. Now we're going to think about the parathyroid, because the parathyroid is influenced by calcitonin, and between parathyroid hormone and calcitonin, those help maintain circulating calcium levels. So again, high and or low calcium levels might be related to parathyroid functioning, and we need to send levels of both to track calcitonin and PTH if that's a concern. There are other reasons for altered calcium levels, which we've talked about in the past. You know, decreased weight-bearing exercise can sometimes lead to leaching of calcium out of bones. Folks with cancer, with tumors in particular, during treatment, if there is a tumor lysis situation where when the tumors break down, they can release calcium in such huge amounts that it creates a physiologic crisis of high calcium levels, hypercalcemia. So what does hypothyroidism look like, where there's not enough secretion of T3 and T4? So we know the thyroid, or I should say T3, T4, have a significant impact on body metabolism. When there's not enough T3, T4, metabolism slows down. So what does somebody look like when they've got low metabolism? Well, they're going to be fatigued, lethargic. They have an intolerance to cold. The dry skin here, loss of body here comes from, again, just everything slows down. So skin is really slow to turn over. Here, that's not where the body's going to spend its energy to make it look healthy and lustrous, if you will. Along with slow metabolism usually comes weight gain, constipation. They will retain fluids. That can be called myxedema, particularly when it's in the face, around the eyes. There may be some congestive heart failure, cardiac enlargement. A goiter is an enlargement of the thyroid gland. And interestingly, you can have goiters with both hyper and hypothyroid. So goiters are just indicative of thyroid problems. Again, this is just another illustration of the signs and symptoms of hypothyroidism. There are a couple of different types. Hashimoto's is considered an autoimmune problem, and it is the most common kind of hypothyroidism. Iodine deficiencies can cause low thyroid, and that can be managed by diet. Where has iodine been added to a diet somewhat insidiously over time?
Salt.
Salt, exactly. Thyroid cancer, tumors on the thyroid can certainly cause hypothyroidism as well. And there are other ways to damage the thyroid. Patients can become critically ill when they reach the point of what's called myxedema coma. It's not common, but this is sort of a long-term chronic hypothyroid situation. In most cases, people are already prone to hypothyroid when this happens. So when they get an acute illness, it can precipitate myxedema coma. If you alter or stop thyroid medications precipitously or quickly, some anesthesias have been shown to precipitate myxedema coma as well. And again, you're looking for those sort of signs of the whole body slowing down. Hypotension, bradycardia. Again, you don't often see those two together. We've talked about a couple of different scenarios where you get hypotension and bradycardia, hypothermia, hyponatremia, low blood sugars, and can ultimately lead to respiratory failure as well. It's an emergency situation, and we essentially need to add the thyroid hormone, which we know of from a pharmacologic perspective as levothyroxine. We've got people can take it by mouth on a daily basis, and we do have it to be administered intravenously in critical situations as well. Again, they may also be given glucose depending on their blood sugars, steroids to help stimulate the thyroid, and maintain vital sign support, keeping patients warm. Fluids you have to be careful with because they may already be holding on to fluid and sort of have that facial and different swelling, distal lower extremities and in the face. And again, watch your electrolytes and glucose. Hyperthyroidism is sort of the flip side of that. This is where we have a hyperactive thyroid gland. On a chronic basis, it can be called Graves' disease. It can also be either iatrogenic or caused by iodine, thyroiditis, goiters. Thyroid cancer can also cause hyperthyroidism. And again, this is the flip side, so you're getting a hyperactive metabolism. These folks don't do well with heat. They're going to be hypertensive, tachycardic. They may be losing weight versus gaining weight. And again, it's going to look like sort of a overall increased metabolic perspective. Along with the tachycardia, they may have different dysrhythmias. This is a tough one to say. Exophthalmos, where their eyes are quite prominent and sort of big and in your face, if you will. Again, hypermetabolic, so everything's moving fast. Like I said, hypertensive, tachycardic, even the GI tract is moving fast with diarrhea. These folks are nervous and restless, and they might have tremors in their hand. They're prone to mood changes. For this one, you can remove either the whole thyroid or part of the thyroid gland. They can administer radioactive iodine to slow it down. And there are other anti-thyroid agents that can be used in certain cases. This is Graves' ophthalmopathy. Again, sort of bulging eyes, big bulging eyes. In both cases, again, hypo and hyperthyroidism, women's menstrual cycles are altered. So that's usually part of a workup if a woman's having a fertility assessment done as well. And even in cases where whether they're well managed and been treated, you worry about a critical incidences of thyroid storm. This is poorly controlled hyperthyroidism. It tends to be acute, the onset of thyroid storm. It is, again, a critical illness, and it can happen after surgery or infection or other stress can precipitate thyroid storm. And so they will often give antithyroid medicines preoperatively if they're going to be doing surgery in that area. And it really significant elevated temperatures, tachycardic, systolic hypertension, nausea, vomiting, diarrhea. It's really extreme cases of what sort of classic hyperthyroidism looks like, but it can progress to full-blown coma and ultimately death if it's not controlled over time. And the antithyroid medications, propranolol is a beta blocker to help slow the heart rate down. And again, more steroids, again, to try to balance out immune system effects. You worry about cardiac dysrhythmias, you've got to lower the temperature, and it says non-salicylate antipyretics. So again, we never use aspirin to lower temperature. We stick to Tylenol and the non-steroidals if necessary. If somebody is on aspirin, whether it's from a cardiac perspective and they've got problems with hyperthyroidism, just want to make sure. Again, I'm not saying that the two are exclusive and that you stop one, you stop the aspirin, because you have to weigh the benefits versus the risks. But you should be aware that salicylates and hyperthyroidism can be problematic. Thyroid cancer is one of the most common forms of endocrine cancer. It tends to be picked up fairly early, and it tends to be highly treatable. There's a higher incidence of thyroid cancer in women and in Asian Americans. Folks who have been exposed to radiation are at a greater risk. Papillary thyroid cancer is the most common. Again, not necessary for the exam, but just so that you know that there are a couple of different forms of thyroid cancer. And typically you can palpate nodes in the neck and feel an enlarged thyroid gland. And again, this is one of those reasons why, you know, in physical exam, we talk about checking for the trachea and making sure it's midline, but that's often when you begin to feel nodes and swelling of the neck and of the thyroid also. Biopsies are typically done by guided by ultrasound. And again, you're also going to watch your serum calcitonin, T3, T4, TSH levels to make sure they're in line also. The calcitonin is particularly associated with medullary thyroid cancer. Management typically includes a thyroidectomy, where either the whole thyroid or part of the thyroid is removed. So if you're going to be having surgery in the neck, you worry about swelling and airway obstruction and potential hemorrhage in that area. Again, the parathyroid is right there on the thyroid gland. When you impact the parathyroid, you worry about hypocalcemia. and all of the signs and symptoms of hypocalcemia, like tetany with the twitching, the numbness, things like that. We know if you're going to administer calcium intravenously, patient needs to be on an EKG monitor, and it should be administered slowly. Some patients are treated with external radiation. We'll talk about external radiation in a couple of weeks, but you have to be very careful with skin integrity for patients who are getting radiation therapy. It can cause impaired skin, make the skin very delicate. You worry about burns in those areas. Very targeted, but nonetheless, it's a concern. Monitor thyroid hormone levels to make sure replacement is done appropriately. And some cases may require chemotherapy, but that's increasingly less common over time. Again, the parathyroid glands are on the thyroid. They produce parathyroid hormone, which helps regulate calcium. The work together with the adrenal, I shouldn't say that, the adrenal glands are down on top of the kidneys. They help the body manage stress. The adrenal glands have two areas, the adrenal cortex and the adrenal medullas. The medulla produces catecholamines, epinephrine, norepinephrine, dopamine. What do you think when you hear epinephrine, norepinephrine, dopamine? What does anything come to mind?
Fight or flight.
Fight or flight, exactly. That's what I think of also. And then when you look at the adrenal cortex, and it produces aldosterone, cortisol, cortisone, androgen, estrogen. Especially when I see the cortisol, I think, managing stress plays an important role there. Some of the sex hormones in terms of estrogen and androgen are there. Cortisone. All of our so cortisone is where sort of the body's natural steroids are produced. Pancreas and the islets of Langerhans. We know that the beta cells in the are where insulin is produced. Alpha cells produce glucagon. And the control of blood glucose is sort of the domain of the pancreas. The thymus, which sits there in the mediastinum, produces our T cells, which play such an important role in our immune systems. The pineal glands produce melatonin, which help regulate sleep and circadian rhythms. And this is again why sleep and maintaining some sort of regular cycle of sleep, dark and light influence the function of the pineal gland and the secretion of melatonin. So even essentially sleeping in a well-lit room when the retina detects light can be problematic. So making sure that there's time spent, regular sleep hygiene in a dark area to maximize melatonin production. And it's funny, this is sort of my own experience. There are many folks who speak very highly of using melatonin as a sleep aid, supposedly natural, secreted by the body. And I do think it's probably better than other sleep aids that can be available. But again, not everything is for everybody. Does anybody know somebody or had any experience with melatonin, taking it to help with sleep?
I used to take it.
How did
I
it
did.
work
I
for you?
did.
Well, I was told to when I got my second concussion because I could not sleep for the life of me.
Yeah.
But I had the worst nightmares I've ever had in my life on it. So I couldn't really sleep with it.
And I heard somebody else say that they had tried it.
I said yes, worked well on me, especially so it's good for jet lag. So there is a special protocol. Yeah, you take it and then you go through it faster and easier.
I
But
have
that's
to
not for everybody, of course. Yes.
I have to say it's supposed to be nice because you're not supposed to wake up with a hangover. It is supposed to be taken when you have a period of 8 hours to sleep. And oh my God, I woke up with such a hangover. I did it for less than a week, and I didn't particularly like it. But again, you got to try to find what works for folks. And then our gonads, the ovaries in women produce, when it secretes hormones to produce female sex characters, to regulate the menstrual cycle, prepares the uterus for pregnancy, mammary glands for lactation, and we know the testes help secrete hormones to produce sperm and testosterone, which drives male sex characteristics and things like that as well. We're going to talk about some other endocrine disorders. Here's where diabetes insipidus comes in. So diabetes insipidus, I need to clear, and I think I said this in the spring. Not completely sure the history of the name, but it's got nothing to do with diabetes mellitus. It's got nothing to do with glucose regulation in the body. It's really about management of fluid levels in the body. Folks who have diabetes insipidus or DI, you might see it in the chart, are excreting significant levels of fluid through their urine and causing problems in fluid balance. So the folks may feel unbelievably thirsty. They want to drink all the time, and they're excreting large amounts of urine. And this is either they're either not producing or not secreting antidiuretic hormone, or the kidneys are not responding to antidiuretic hormone. And this ends up creating problems in fluid balance and electrolyte imbalances. And again, either they're not making or secreting ADH, or the kidneys aren't responding to it. So central or neurogenic DI means that it's something up in the head, and this is where I was saying that head injury, brain surgery, a tumor, something that's altering usually intracranial pressure, increasing intracranial pressure, is interfering with the production of antidiuretic hormone. Nephrogenic means that the kidneys are not responding to antidiuretic hormone. And in primary diabetes insipidus, there's something going on in the thirst center in the brain, and it's just calling for more and more water intake. Almost all of these patients are experiencing extreme thirst and excretion of dilute urine. So they're putting out large amounts of urine, but its urine osmolality is very low. And they could be putting out, I mean, liters and liters per hour of urine. Sometimes it starts subtly with night urination, nocturia, if you will, bedwetting unexpectedly. In folks who have had surgery or stroke or head injury, especially if they've still got an indwelling catheter in, you just see significant increases in urine output. If they become hypovolemic, you're going to see all those signs: decreased skin turgor, hypotension, tachycardia, and ultimately hypovolemic shock if we're not keeping up with the fluid output. Other things, signs and symptoms that come with the hypovolemia: irritability, hypernatremia. So again, urine osmolality is very low, so the urine's not concentrated. Lots and lots of excess fluid is being excreted in the urine, but the electrolytes are left in the body. So you have what was essentially a normal sodium level, but if you take off extra fluid, it leaves highly concentrated blood, if you will, high levels of sodium, increased serum osmolality. So you're going to see a low urine osmolality with a high serum osmolality. So we're going to rehydrate them. We may need to give electrolyte replacement to make sure balance is maintained. If you are giving like D5 fluid with sugar, watch your blood sugar levels, do your finger sticks. Monitor vital signs, monitor level of consciousness, monitor I's and O's, and the DDAVP, what's it? It begins with an O, not oxytocin, oxy. I'm gonna have to look it up because it's not coming to me. Can be administered as a medication. It's sort of it's a produced ADH that acts like ADH. Low sodium diet. NSAIDs may help influence responsiveness to antidiuretic hormone. And thiazide diuretics, which interestingly enough, you would think administering a diuretic, but it can help influence how nephrons are responding to antidiuretic hormone also. So again, sort of a graphic cartoon of diabetes insipidus. Maybe there's a head injury, pituitary tumor, craniotomy, some sort of surgery. The pituitary gland sort of gets impacted. Antidiuretic hormone is not secreted. So the kidneys start excreting lots and lots of urine. You can give vasopressin or DDAVP to help slow down the excretion of water. And again, signs and symptoms: increased urine output, decreased urine specific gravity, decreased urine osmolality. The patient looks hypovolemic, they're thirsty. And again, the signs of hypovolemia: tachycardia with decreased blood pressure. SIADH, syndrome of inappropriate ADH. So in this case, there's excess antidiuretic hormone. These folks are not excreting urine. They're not excreting fluids. There's not enough antidiuretic hormone. And so they're retaining water. This can happen with folks with heart failure or also with a brain injury or surgery. There are also certain lung cancers that can produce an ADH-like hormone. And again, you're going to end up with an imbalance of fluids and electrolytes. So these folks are retaining fluids. That means they're going to have a lower sodium. The kidneys are going to reabsorb free water. These, again, they're retaining fluid. They look bloated. They've got edema in their extremities. And they're prone to, again, changes in mental status and potentially seizures. This is where, this is folks with SIADH, we may actually put a fluid restriction on them, trying to increase the level of sodium, monitoring electrolytes, monitoring level of consciousness, heart sounds, lung sounds, daily weights. Be concerned about seizure precautions. Keep the patient oriented. And so here is a chart where you're comparing DI to SIADH. High urine output in DI, low levels of antidiuretic hormone, resulting in hypernatremia, dehydration, hypovolemia, versus SIADH, low urine output, but high levels of antidiuretic hormone, low sodium levels. Folks look overhydrated, fluid volume excess, they're retaining fluid, but all patients will report being thirsty, things like that. And again, so, and then this slide is just, again, what happens when there's either too much ADH or too little ADH, which sort of goes back to the previous slide. So a patient with SIADH is treated with water restriction and administration of IV fluids. The nurse evaluates the treatment has been effective when the patient experiences what? So SIADH is decreased urine output because of inappropriate ADH levels. So how do we know when they're getting better or if treatment's effective? Well, first, B. So we know, again, just trying to reason my way through it. If their urine output is low with SIADH, first off, we want to increase urine output. So we can cross off C and D. If we have decreased urine output as a symptom, that means there's going to be they're going to appear hyponatremic when they're acute. So we're going to, when we see increasing sodium levels, we know things are getting better. So that sort of crosses out A. So we're left, as you said, I believe it was Jonathan, with B as being the best option if you work your way through it. And I think in the notes, that's what B says, what the slide says. So B is the correct answer. So this one, you're teaching a patient with chronic SIADH about long-term management of the disorder. The nurse determines that the patient needs additional instruction when they say, so the first option is, I need to weigh myself daily and report any sudden weight loss or weight gain. Well, if we're talking about fluids, that's probably a good thing. So that's probably not it. I need to limit my fluid intake to no more than 1 quart of liquids per day. Well, fluid restrictions is a possibility. So let's hold on that one because the 1 quart might be a question. I will eat foods high in potassium because the diuretics can cause potassium loss. Well, if they're retaining fluid, they might be on diuretics, and they're right. Potassium can be lost with loop diuretics. So that doesn't sound all that bad. I need to shop for foods that are low in sodium and avoid adding salt to foods. Well, again, they're probably hyponatremic because they're retaining fluids. So that one sounds pretty okay also, because we don't want them retaining fluids. So which is the right answer here?
4.
4? Yeah. So even though sodium helps retain fluids, they tend to be hyponatremic. So they actually often need a little bit more sodium because we're concerned about the ill effects of hyponatremia. So patients admitted to the hospital with a diagnosis of diabetes insipidus. The nurse should be aware of what primary characteristics of diabetes insipidus. Decreased urinary output and decreased plasma osmolality. Excretion of large quantities of urine with very low specific gravity and urine osmolality. Or hypertension, weight gain, and bradycardia.
B.
B.
Low urine osmolality, large quantities of urine. Exactly. All right. Why don't we take 10 minutes? Everybody come back at 11:30, and we'll get started with the next couple of topics, okay? And I'm going to hold on recording. We're going to resume recording. Any questions so far? Keep on marching on.
Yep.
Okay. So next we're moving to disorder known as Cushing's disorder, and there's sort of two sides of Cushing's. There's the syndrome, and then there's the Cushing's disease. So the syndrome is usually in response to something in the body that the patient was using corticosteroids, glucocorticosteroids, and the body is responding to long-term exposure to excess cortisols, if you will. Cushing's disease, which is where, for some reason, usually a pituitary tumor, the adrenal cortex is excreting excess ACTH, which stimulates cortisol, which is a stress hormone. And when cortisol's excreted, again, typically cortisol excretion is a way for the body to handle stress. It is normal under stressful situations, and it impacts the body's use of carbohydrates, fats, proteins, and things like that. So when there's too much cortisol, the body has a specific response to that. And what does that response look like? Well, weight gain for one thing. Because the body is physiologically sensing stress, it's going to prepare for long term, and it's going to hold on to different energy sources for potential for the future. So there may be weight gain. There may be hyperglycemia related to glucose intolerance. On the other hand, while there's increased fat tissue, there's muscle wasting, which leads to weakness, osteoporosis, back pain, loss of collagen. People's skin gets thin, they bruise easily. Maintaining skin integrity becomes increasingly difficult. There's delayed wound healing. So this with Cushing syndrome, these are all the signs of this, if you will, the side effects of using steroids in a patient. They get irritable. They have issues with steroid-induced psychosis, anxiety, things like that. Retaining fluids, again, weight gain. So these are all those side effects of using corticosteroids. When we administer steroids to our patients, this is what Cushing syndrome looks like, because the body's making excess naturally occurring steroids. Hypertension can be a problem. If there's excess adrenal secretions, severe acne, women take on more male characteristics and men take on more female characteristics. Hands and feet can grow, deepening of the voice, as I said, hypertension, dysphagia, over time visual changes, joint changes, joint pain, and those striae on the abdomen and the limbs, usually the upper limbs, both the arms and the thighs as well. So again here, women, again, both men and women get that round moon face, shaped face. Women will start getting hair on their face. They bruise easily, thin skins, abdominal weight gain. The stretch marks or the striae can be seen on the abdomen. The dorsal buffalo hump, the fat pad, the dorsal fat pad can develop. Muscle weakness, osteoporosis, poorly healing skin wounds. It's a picture of that moon face, the striae, abdominal weight gain. So how do we go about diagnosing it? Well, blood cortisol levels, a 24-hour urine collection. They'll try a dexamethasone suppression test, urine test, CAT scans looking for, both the CAT scan and the MRIs are looking for tumors, measuring ACTH levels. Again, differentiating Cushing syndrome from Cushing disease. So with Cushing syndrome, ACTH will be low. In Cushing's disease, it will be high. Again, one's indicative of a more, I'm going to say natural process within the body versus in response to steroids that have been administered, if you will. Hypokalemia, alkalosis. From our nursing concerns or nursing diagnoses, risk for infection because of issues with resistance and suppressed immune system, imbalanced nutrition. We know administered steroids and naturally occurring steroids increase appetite, but also because of the fatigue and the muscle weakness, there may be increased inactivity. Disturbed body image between the weight gain, the striae, the development of the fat hump, retention of fluids, the moon face, all sorts of issues that people go through in terms of how they look, which is changing. And impaired skin integrity. Fragile skin, poorly healing wounds lead to problems with skin integrity. Emotional support's important, especially when you're dealing with folks with body image issues, patients. Again, mental status in terms of emotion, restlessness, irritability, paranoia, psychosis, those issues. So making sure you're talking to folks and assessing their mental status and what's going on from that perspective. Dealing with any pain issues they may have, if radiation's going to be an issue or part of a treatment because of tumors and oncologic processes, and then hypophosectomy if they're going to go in and surgically impact the pituitary gland. Hypophosectomy is where they go through the nose to for surgical interventions on the pituitary gland. It's less risk intensive than an open craniotomy. Apparently the pituitary gland's readily available via the nose, heals faster, but still, you know, obviously still a challenging surgery. Overall, we want to get that hormone secretion, hormone levels to normal or expected. And what further treatments are depends on both the cause. If you're removing a tumor from the pituitary, you may have to replace the corticosteroid. And again, over time, if you're going in and doing not over time, but post-operatively, if you're doing a hypophosectomy, risk for increased intracranial pressure is possible. So again, assessing eyes and nose, being on the lookout for potential of diabetes insipidus is important. If the cause is because we've been administering steroids, you're going to taper down the doses, decrease the dose in some way, maybe go to an alternate day, decrease doses, but you can't just withdraw steroids. You've got to taper people off of steroids sort of once they've been started. More about the hypophosectomy surgery. So again, it can either be done through a craniotomy or this transsphenoidal hypophosectomy where they go through the nose. Increased intracranial pressure is still a concern, always a risk for bleeding with a surgical procedure. You are still going into the cranium, so you're breaking through the meninges, so you worry about both meningitis as well as post-operatively a CSF leak. And the risk post-operatively is hypopituitarism. If you've, when you remove the tumor, do you take part of the pituitary gland? Does the functioning of the gland decrease? So those are all concerns. We're having a problem in the head. We're going to go in and do surgery in the cranium. So neuro checks, level of conscious assessment are key and critical. You're going to elevate the head of the bed, and all those things we do to prevent increased intracranial pressure are important. So again, increase the head of the bed, no sneezing, no coughing, no Valsalva maneuvers. We want nice, regular, almost soft bowel movements. No blowing the nose. Monitor for bleeding and hemorrhage. Again, we broke through the meninges to get out something bad, so it was necessary, but we need to let that tear heal. So we're on the lookout for CSF leaks. And we know how dirty the mouth is, so we don't want to break up all by brushing the teeth. You can do mouth washes and things like that to keep the mouth as fresh as possible, but we don't actually want lots of breaking up of potential bacteria in the mouth going up into the sinuses. Watch for signs and symptoms of DI or SIADH. So you're monitoring your eyes and nose, their thirst, their urine and serum osmolalities, urine specific gravity, and administer the steroids or any other hormone replacements as necessary. We want symptoms to recede. We want to avoid infection and other complications. We want folks to feel better about themselves. And make sure the patient has an active role in their plan, and their therapeutic plan. So again, we're looking with Cushing's syndrome, we're going to do our assessments. We're looking for signs of cardiovascular function, diabetes, infection, with what is going to complicate the scenario for these patients, monitoring daily weights, glucoses, any signs and symptoms of inflammation or infection, any risks for clotting, and again, supporting them emotionally, supporting patients in terms of their body image issues, and hopefully once the balance of hormones gets back to what's expected, they'll start feeling better, feeling less stress, and can continue on. Let's leave this for a little bit later, and let's go on. What is this? Yeah. I'm so confused. Yeah, let's go on and do Addison's disease, and we'll might come back to this later. So Addison's disease is caused by adrenal insufficiency. There's somebody in US history who suffered from Addison's disease.
John F. Kennedy.
John F. Kennedy, that is correct, Kristen. Back in the day, this was kept huge, big secret. Apparently everybody knew, but this was the sort of thing that didn't get published the way it would be today. But again, if you think, the adrenal gland is does secrete cortisol, does help manage stress. In many cases, Addison's is precipitated by some sort of stress event, physiologic or emotional, infection, trauma, surgery, or this is why we have to taper steroids, when you stop steroids precipitously without tapering them off. And again, this can be fatal. Hyponatremia, hyperkalemia, hypoglycemia, leading to shock. So this is actually quite serious. there's just not enough circulating glucocorticoids in the body. And so that's the primary reason. Secondary is there's a lack of pituitary ACTH, which stimulates the adrenal gland, which again leads to decreased, not enough circulating corticosteroids. Most cases, it's an autoimmune issue that's happening, although tuberculosis, infection, HIV, AIDS, and cancer can lead to Addison's. There are some drugs that have been shown to be related to it. And then, of course, if you have damage to the adrenal gland or adrenalectomy, that would precipitate Addison's disease also. So what do these folks look like? Again, they're almost not able to develop a stress reaction, so they're going to be lethargic. They're going to be fatigued, weak, and yet there'll be weight loss, GI problems. Orthostatic hypotension is a big deal with these folks. A lot of blood pressure dysregulation, hyperpigmented skin, hypoglycemia, hyponatremia, hyperkalemia, hypercalcemia. So they get this sort of bronzy look. The way their hair grows and gets distributed is a problem. Weight loss, weakness, fatigue, hypotension, hypoglycemia, leading to kidney problems with decreased serum sodiums, increased potassium. Again, another potentially fatal diagnosis for folks. There's a picture of that sort of bronzy hyperpigmentation. So what are we going to do? We're going to draw blood samples. We're going to and take urine samples as well. We're looking for urine cortisol and aldosterone. We're looking for ACTH levels in the blood to try to differentiate a primary versus a secondary causes, potassium levels, chloride, sodium, and glucose levels, anemia, increased BUN, EKG changes, diagnostic scans like CAT scan and MRI looking for tumors, Addisonian crisis. These are either sudden or acute changes resulting in adrenal insufficiency. Again, big decreases in these hormones. It could be related to infection. So all of the same triggers of long-term disease can precipitate a crisis as well. Looks hypotensive, tachycardic, dehydrated, low sodium, high potassium, low glucose. Those same symptoms we talked about a couple of slides earlier. Headache, abdominal pain, back pain, weakness, fatigue, irritability, confusion. The hypotension can be profound, which ends up leading to shock. In this case, we're going to administer glucocorticoid steroids, our Solucortef that we talked about last week also, monitor eyes and nose, protect from infection. assess neurostatus over time, looking for subtle changes. And again, I will say that particularly folks who are on IV steroids or even by mouth prednisone sometimes, those mental status changes, paranoia and psychosis are very real. Glucose monitoring and management is very real. Once you start the steroids, hyperglycemia becomes an issue. So you've got to do your finger sticks on a regular basis as well. And over time, you want to try to correct the underlying cause. Maybe they need long-term hydrocortisone, Florinef, because it's easier for me to pronounce. The fludrocortisone can be administered over time to help maintain fluid balance. Sometimes these folks need a little bit of extra salt to help them retain fluids. And you're always on the lookout for Addisonian crisis and avoiding hypotensive crisis. But that will require monitoring blood pressure, fluid status, and administering hydrocortisone replacements to help manage a crisis. Folks often require lifelong treatment with steroids. When folks are under stress, they need to often require higher doses. And again, when we're talking stress, it's not just emotional. We're talking about physiologic stress as well. So illnesses, signs of infection, even temperature changes in the environment can precipitate crisis and require changes in their dosing of their steroids. They need to rest, they need to avoid stress, they need to not get sick, they need to have a balanced, healthy lifestyle. They need to know what the signs of under medication it is. And they should probably have a medic alert bracelet so that, number one, in an emergency, it's recognized that they're on steroids, and two, in the event of a crisis, the information is available and you can sort of relate the signs and symptoms to potentially needing additional steroids. We've talked about steroids and administering steroids in the past. Again, we do it so often these days. They can immunosuppress people. They can help maintain blood pressure. They have anti-inflammatory actions. All of these are positive when they're needed. But we also know that there are a fair number of risks that come along with them. You might need to use them to suppress the immune system when you have a hyperactive immune system. But on the other hand, we need the immune system to fight off other infections and other problems within the body. I was going to say within the body. There are significant side effects. You think to Cushing's, water retention, weight shifting, moon face, the striae of the skin, the thinning of the skin, the difficulty in wound healing. So there are definitely any number of side effects when you're administering corticosteroids. Mood behavior changes, and the risk of precipitating an adrenal crisis if the dosage are not tapered appropriately. What time of day are steroids best administered, or is there anything special when we administer steroids that we need to remember?
In the morning.
In the morning, that is correct. Anything else?
With food?
With food. Yep. Their risk for peptic ulcer disease is really kind of significant. And again, patients need to understand they cannot just stop their steroids. They need to be tapered off. And in particular, when they're treating Addison's disease, they may even need to increase the dose when something is going on, infection, illness, stress, things like that. These patients need to be counseled to do weight-bearing exercises to counteract osteoporosis. Take them with meals, get good rest, things like that. They may be retaining fluid, so watch their sodium in the diet. Monitor for hyperglycemia, talked about that. In these cases, you need to worry about heartburn and epigastric pain. That could be sign of a developing peptic ulcer. Wounds are healed more slowly, so they need to prevent injuries, prevent infections. And again, they need to make sure all healthcare providers are aware of that this is on their in their daily regime and their medication lists. All right, so I know we just had a break. Let's take another 10-minute break. Let's all come back at 12:10. We'll do this case study. We'll do another one, and we'll be kind of quick today, okay? I'm gonna pause recording. Okay, so this is the Cushing's syndrome case study. So we've got a gentleman, 60 years old. He's got a history of COPD related to a history of cigarette smoking. He's been taking oral prednisone for 10 months to help manage his COPD. He uses oxygen at home. He has a blood pressure of 180/94. What do we think about that in general?
We don't like that.
A little on the high side. He's got striae in his trunk and his thighs, full-looking face, truncal obesity, and upper back fat and thin extremities. And the nurse is worried that he's developed Cushing's syndrome. What are some of the symptoms that you are going to be concerned about?
Well, the striae you just spoke of is one of them.
Yes.
Blood pressure?
Blood pressure. I'm going to go back to the slide so you can.
Oh, the truncal obesity.
Trunk obesity, yep.
Full looking face.
Full looking face.
The thin extremities.
Thin extremities, good.
High blood pressure, high glucose, redness of the face.
So those are other things, the blood pressure he's got. The other two things are things you'll be looking for. And so now they weren't mentioned, but he's got the buffalo hump, the fat pad on the back. Thinning hair is something you would look for. It's not mentioned. So you said high glucose, Eugene, is an important one. For sure. And so if you think he's got, what do you think the most likely the cause of the disease is?
He's using steroids for 10 months.
Yeah, the prolonged use.
Yep. And so again, in this case, it's considered iatrogenic. Again, they'll probably do a study to confirm that, but I'm sorry. They will confirm that. All right. I got another one. I need to new share. New share. Okay. All right. So this is definitely a longer story. I'm going to give you a moment to read it. I don't need to read it out loud to you. All right. So there's a fair bit of information here. 65-year-old gentleman. He's got a 5-day history of flu-like symptoms with shortness of breath on exertion, palpitations, chest pain, insomnia, fatigue. He has a diagnosis of Graves' disease and takes methimazole for treatment. His other history includes heart failure, hypertension. He's not been consistent with his antihypertensives. And today he's got a blood pressure of 150/90, 124 and irregular, respiratory rate of 20, temps 100.2. He's 5'8", weighs 132 pounds. I should live so long. He appears anxious and restless, loud heart sounds, 1+ pitting edema, bilateral lower extremities, diminished breath sounds with crackles in the bases bilaterally, He begins to cry when he tells you he recently lost his wife and someone has made his belt smaller so he could tighten it. A lot of information there. Here are some lab tests. His H&H is 11.8, 36. What was the little tip I gave you about hemoglobin hematocrit when you look at it?
Should be 3 times.
Right.
Remember?
So that's pretty close, right? 3 times 12 equals 36. 3 times 11.8. That's pretty close. So what's that tell us? Kind of, sort of.
It's okay.
That from a fluid volume status, he's not excessively hypovolemic or hypervolemic. Might still be anemic, but he's not at 11.8 and 36. So his fluid status is kind of okay. SED rate's 48. What is this ESR SED rate tell you? When do you expect to see a change in the sedimentation rate?
Inflammation.
Inflammation, right. Sodium 141. That doesn't scream at me. Does it scream at you?
Nope.
I'm terrible with lab values, to be honest with you. Potassium 4.7. I can live with that. Chloride 101. I probably shouldn't say this, but who cares about the chloride? BUN 33. Creatinine 1.9. Creatinine's a little high, but not tragically so. His T4 is 14. His T3 is 230. But I totally need to look those up.
Free T4 is, it goes up to 12. It's like 5 to 12. And T3 goes up to 220. So they're both slightly high.
Okay, thank you. Very good. All right, and what's it mean when T3 and T4 are slightly elevated? What organ does that take you to?
An increase in
Thyroid.
metabolic rate.
Takes you to the thyroid. Let's go one step at a time. And then Linda, what did you say?
It increases your metabolic rate.
They'll increase your metabolic rate. Correct. Okay, so when we're looking at hypermetabolism, back to these symptoms, which of these symptoms talk to you about hypermetabolism, increased metabolic rate, if you will?
He's 5'8" and only 132 pounds.
Yep.
Increased
Yes.
weight loss.
Know whether that's a change or not, but certainly
Plus, he had to punch several holes in his belt to make it fit.
that's what tells you there's the change, if you will. Good one, Jonathan.
Fever and increased heart rate.
Increased heart rate, fever, good.
Hypertension, especially systolic.
Yep.
History of Graves' disease.
So he's got that history of Graves' disease, so that's a concern for sure.
It looks like he also has an infection going on. Maybe.
Potentially. There's something else here in the vital signs that says potential for hypermetabolism. Somebody said the heart rate. Is there anything else about that heart?
It's irregular.
It's irregular. So again, those dysrhythmias, whether it's the odd ectopic beat or whether he's got a little bit of AFib going on, again, you're not going to be able to know that just by listening, but the fact that it's irregular should say, wow, I should be getting an EKG on this. And again, he's complaining of some shortness of breath. Could be related to the flu-like symptoms, maybe he's related to the, the hyper metabolism thing. He's, and again, I understand that, he's just lost his wife, so he's emotional and all. So that's, again, is there anxiety there? It says right there, he appears anxious and restless. Again, that could potentially be a sign of hypermetabolism also. All right, we went through the lab results. Anything else we should do in terms of assessing, given his Graves' disease and his presentation? So let's go back to what we've already collected. All right, so he's got dyspnea on exertion, palpitations, chest pain, insomnia, and fatigue. What do you think they're going to follow up on just with that sentence alone? What do you need?
EKG.
EKG. What are you going to do for the, again, talk assessment right now. What are you going to do for the dyspnea?
Check O2, give oxygen if needed.
There you go. Check the O2 sat, oxygen if needed. We hear crack. Did I hear crack? We heard crackles when we listened to him. So again, he's admitted. So somebody should have done a chest X-ray. Take a look at that. What kind of questions are you going to ask him? Given, again, just focus on that one sentence: chest pain, insomnia, fatigue, palpitations. Focus on chest pain.
Can you describe it? Does it radiate anywhere?
Just say old carts to me. That'll work, right?
All right.
That's okay, but I'm just trying to make it easy for you guys, going back to your roots. Insomnia and fatigue. Again, let's make sure we understand that. What time does he go to bed? What time does he wake up? How does it feel being in bed? Does he do anything during the day that makes him feel more fatigued? Those sorts of things. You just want some more information on that. Does he feel the palpitations? It says he came in with complaints of palpitations, so you can assume he does. And then you heard, felt that it was irregular. But just to confirm that. He's, again, appears restless and anxious. Any questions you might ask him about your concerns regarding those issues?
Ask him if anything's stressing him out.
Right.
Like a psychological assessment type thing.
Yep. Is anything making him anxious? And again, expressing sympathy about his wife. How has that changed his day to day? If she was the only one who cooked in the household, yes, he could be hypermetabolic, but he may also not know how to cook and or buy appropriate food. What's his appetite like? Things like that. Is he having trouble concentrating? I'm sort of mixing things in. I'm not being consistent. I apologize. from a GI perspective, hypermetabolic, what did I say comes, what happens when your GI tract is moving faster?
You absorb less nutrients.
Because
It doesn't have enough time to actually be absorbed.
things are zipping through, AKA diarrhea. So again, let's ask him about that because it's not explicit in his story. Any changes in vision, things like that? All right, so let's see. Sorry, my fingers are. All right, let's leave the priority problems for now. All right, so now he's increasingly restless, disoriented to person, place, and time. Vital signs, blood pressure's up even higher, 174/82. Heart rate is 180 in irregular, respiratory rate 32 in labored, 104 degrees Fahrenheit, and his EKG shows atrial fibrillation. What do you think this might be?
Thyroid storm.
Thyroid storm. There you go. What do you think you're going to do? What's your biggest concern here?
His temperature right now,
Mm-hmm.
or his heart rate.
There you go. Go back to ABCs. I know 104 is scary in an adult, but heart rate of 180 and irregular and let's assume this is new onset atrial fibrillation. ABCs is going to take priority status there. So if you're the nurse on the shift with this guy, what are you going to, I mean, literally, what's the first thing you're going to do? You're going to manage this alone?
Maybe call a rapid or something, or at least the doctor.
There you go. This is a patient who needs a rapid response. Does anybody want to take a shot at putting together an S-bar for the call to the clinician that first shows up? So S. So, hi, I'm Carol Ann. I'm the nurse taking care of Mr. B. Mr. B was admitted today. Now his blood pressure is elevated to 174/82. It's a heart rate of 180. It's irregular, and his EKG shows atrial fibrillation. His respiratory rate's 32 in labored, and his temperature is 104 Fahrenheit. He has a history of hyperthyroidism. So that's our background now. He's got a history of hyperthyroidism. He was admitted because of signs and symptoms, including bilateral edema, restlessness, fine crackles in the bases. Anything you've done for him? I believe he's got thyroid storm going on, and I need the team to come see him.
So is the crackles and the edema anything related to thyroid hyperthyroidism? Because I'm not sure if I've seen that.
It can be. I probably should have also mentioned he's got a history of congestive heart failure.
Got it.
That probably should have precipitated that also. So in this gentleman's case, they'll often, or actually anybody, new onset AFib, 180. They'll try some cardizem intravenously. You guys can do the math as practice. Why do you think what was his risk factor for developing thyroid storm?
He had hyperthyroidism and then a recent stressful event like his wife passing.
Very good. Also potential for infection, so physiologic stress as well. He's been inconsistent with taking his medications, whether it's the antihypertension medicines or the thyroid medicines. Sort of any of those are possible. So for patients that have the exophthalmos and if they're experiencing photophobia and dry eyes, how can we help him? What sort of interventions can we use for this gentleman, recommend for this gentleman? So again, he's got, if you will, big bulging eyeballs.
Artificial tears and the sunglasses.
Sunglasses. Are we
B and C both seem good.
vision changes? I think this dude might be prone to dry eye syndrome, so some artificial tears. Do we want to tape his eyes closed? No, we don't. But warm compresses to the eyes might be soothing to him. I mean, let's face it, everybody should wear sunglasses nowadays when they go out to protect the eyes, cataracts and things like, to prevent cataracts and all. But in particular, if you've got even more tissue exposed, can be helpful. Let's take a minute and just go back to the thyroid storm. Besides trying to slow down the heart rate, is there anything else we might want to think about? What's our assessments going to look like over time, this next few hours with this gentleman? Are you just going to give the cardizem and walk away?
Continue monitoring heart rate and rhythm.
Right? His heart rate, his respiratory rate was 32. And again, he's labored breathing, so we popped him on oxygen. Doesn't have to stay on it forever. If his respiratory rate comes down and his O2 sat remains stable, we can wean off the oxygen. It could have been just an acute support in that moment. With a heart rate of 180 irregular and atrial fibrillation. Again, how does atrial fibrillation potentially impact congestive heart failure?
Blood blood backs up from the right side.
And
Because it,
why is that, Kevin?
because it can't pump it out efficiently.
What's the problem? What happens with atrial fibrillation? I don't know why I remember this, but I know Eugene. Didn't you do
Yeah.
AFib last semester, the presentation? Who else was on your team? Who else should I torture?
I think we did COPD.
Oh, you did? I'm sorry. Who did AFib last semester? Right, so, all right, make me do it. That's fine. It's that loss of the atrial kick. The heart's supposed to be a highly coordinated thing. Atrium contracts, filling the ventricle, ventricle contracts, shooting it out. Atrium, ventricle, atrium, ventricle. Now with atrial fibrillation, you've got no coordinated contraction with the atrium. The ventricle's still doing its thing, but you lose that really efficient fulfilling from the atrium because you just have it fibrillating like that. So Kevin's right. Blood's going to back up because it's not emptying out of the right atrium effectively, leading to worsening congestive heart failure. So monitor for all those signs of worsening congestive heart failure. JVD, edema, increased crackles, decreased urine output, stuff like that. Okay? Does that ring a bell? Lie to me.
Yeah.
Thank you. All right, what's this? So he's getting discharge instructions. I will take, it doesn't even mention which medication. Let me see if I have any notes on which freaking medication it is. No. I will take this medication on a full stomach. If I get a sore throat, ice chips should help me feel better. I should see an improvement in my symptoms by tomorrow, or I will follow the precautions for 2 weeks to keep my family safe. Again, not knowing exactly what the discharge instructions are, this makes it a little more difficult. But in general, if he's being treated for hyperactive thyroid, let's say whether they're doing radiation or surgery, you know, a sore throat, ice chips are not just the solution. They really need to be
Should be A.
well, again, not knowing what the medication is, this question sort of comes out of left field. This wasn't really the right question to ask here. But I believe it's related to the fact that he's getting radiation for his thyroid. And
Probably D then.
actually B, because a sore throat related to the radiation is very common, and ice chips do help him feel better and helps also keep the area more moist. They can also do a salt water gargle, also can be soothing for patients. That question just came out of left field without enough information. All right. So That's all for today. That was pretty good, huh? Any questions? Any, I have to go and I have to look at ATI to make sure A and B are open. What else do I need to do?
So Carol Ann, the one that's due the 14th, that's the date that we take it?
No. Both A and B, you can take it any time in advance of that. In fact, but A, remember, you have to take it till you get an 85%. So you need to retake it until you get 85%. I'm going to, usually we put 24 hours in between, but because it's been closed, I'll decrease that so that you can take it sooner, so that you have enough time to take it again and again if needed. So A, you have to get 85% before the due date. B, again, you can take any time, but you take it once, and then you have to hand in the handwritten remediation, and you can upload that in Husky CT. Does that make sense, James?
Yeah, but the one that says predictor practice assignment A, 85%,
Yep.
that's the one that we can take anytime?
You can take them, all the practice tests, you can take them at any time. And in fact, you need to take it in advance of that because you have to get 85%. So you need time to retake it if necessary.
Okay. All right, thank you.
Okay. Okay. I'm around. If you have questions, text me or email me. I'll get the blueprint out for next week's quiz. And I bet you we'll talk later, okay?
Okay.
All right, guys, and I'll post the recording. Thank you very much.
Thank you, Carol Ann.
Bye.
Thank you.
Thanks,
Thank
Carolyn.
you.
Take care, everybody.
Thank you, Carol Ann.